Welcome and thank you for joining us for tonight's webinar, Trauma Informed Care. Before we begin, I'd like to acknowledge the traditional custodians of the land that we live and work on. For myself on the Central Coast, as Darkinjung land, and I'd also like to pay respect to all elders past, present, and emerging. Now, my name is Sydney and I'm from the PHN Education team. I'm joined tonight by Dr. Gordon Lau, Olivia Gregg, and Dr. Jamie Navali. Gordon is a medical doctor and physiotherapist with over a decade of experience on the Central Coast, specializing in pediatrics, mental health, and musculoskeletal sports medicine. He is known for his engaging, collaborative approach and injects fun into consultations to optimize patient outcomes. Gordon splits his time between a general practice clinic, a youth focused mental health service, and as a medical educator for local GP registrars. We are also joined tonight by Olivia Gregg. Olivia is a clinical nurse consultant with CAMS on the Central Coast, and rounding out our team is Dr. Jamie Navali, who is a Health Pathways clinical editor. Now, a few things to let you know about this session. It will be recorded and available for you to view in our education library in a few days' time, as well as a copy of the PowerPoint presentation. You will find a little section called handouts in your control panel. We have already uploaded the slides there if you would like to take the PDF away with you today. Now, as attendees, your camera and microphone are automatically disabled. However, if you have any questions during the presentation, please send these through the question box, which you will find located in your control panel, and these will be answered at the end of the session. An evaluation will also come to you directly after the session ends. We encourage you to fill it out because your feedback is so important to us as it enables us. This session is also accredited with RACG next week. Now it is my great pleasure to hand over to Olivia Gregg.
Thank you, Sydney. Thank you, everyone, for attending tonight. It is always a great pleasure to be able to deliver these webinars to the amazing and awesome GPs on the Central Coast and in the Hunter. Tonight, thank you, Dr. Lau, for presenting. It's a great topic, and it's a topic that's in continuous demand, especially around the young child and adolescent cohort that we experience at CAMS. Without any further ado, I will hand over to Dr. Lau because I know it is an amazing session and there will be many questions afterwards.
Thank you so much, Olivia. Goodness, Dr. Lau sounds very scary, but please call me Gordon. It's much easier that way. So yeah, so I am Gordon, and I'm one of the actual kind of doctors who work between these three places. I currently spend my time working at Headspace, um, and also work at Mingara Medical, and I'm also a medical educator for the RACGP. But Sky, the good news is that I have nothing to disclose in regards to any conflicts of interest. So let's dive into the topic of trauma-informed care because there's lots of stuff we can talk about tonight, and I hope to actually give you a bit more of an understanding about the area and why it is so important in our everyday life as doctors and health professionals working with young people, but also too working with older people in the community as well, who may have still got a legacy of the past, still battling through their traumas. I too would like to acknowledge the traditional custodians of the lands that we are logging in from today, and I pay my respects to the elders past, present, and those who are emerging. I also want to extend this welcome to people who identify as being gender diverse, people of all ages, people with disabilities, and also people who come from culturally and linguistically diverse backgrounds, because we are all welcomed here together, and it's a pleasure for me to be able to share this time with yourself tonight. Here are our learning objectives. As you can see, we do have quite a few things in place, so we're going to be a little bit ambitious maybe to covering all this in an hour, but I'm sure that we can try and do our best to help you understand this topic a bit more. As always, when we talk about any kind of our mental health related topics there, we know that this is a very sensitive topic and many of us in the community do have lived experience ourselves. So I want to send my apologies in advance if I do trigger any negative emotions or distress in any way. Please feel free to take a moment and log off if you need to. If you are feeling triggered or feeling a bit overwhelmed, please rest assured that this session is being recorded. And when you want to come back and check it out again, you can do so in your own time. But make sure you do look after yourself because you are very important as well too. Without more to do, let's go into trauma-informed care. So I guess first of all, we need to actually know what is trauma-informed care. Um, So I guess the big word here is, first of all, what is trauma? Trauma itself can come in many different forms, and we have different ways of trying to actually understand what trauma actually means. If you're looking at a more of a biological sense, we'll often think about a wound and an injury of some sort. If you look at our other kind of ways of interpreting it, for example, more of our psychological aspects there, we can actually consider a trauma as in a deeply disturbing kind of situation or experience that we have actually gone through. So we're going to use that as our basis here and the foundation to understand that this is actually a trauma, a wound, a disturbing experience that we have actually encountered ourselves, and that's what we're going to be coding as trauma. That being said, though, trauma itself can also be classified as trauma with a big T and trauma with a little t. And what I mean by that is that when we talk about trauma with a big T, these are things that people will say, oh, no, without a doubt, definitely traumatic. So, for example, things like your warfare, famine, natural disasters, which we've been impacted by, everyone will actually understand and will agree with you that these are trauma with a big T. And you can also even say as well too that these traumas with a big T will often have many people all impacted by this situation all at once. So what does trauma with a small t look like then in that case? If they're not these big, massive things, trauma with a small t itself will often be our everyday things that we encounter, which actually makes us feel uncomfortable or actually hurts us in some way, shape, or form. And in this situation here, or even though these smaller traumas themselves may not actually cause significant impact upon your well-being by itself as it stands alone, in a cumulative sense, you can actually have a situation where you could be dying from a dozen paper cuts. And that's why we actually look at the trauma of a small t more being a cumulative effect to have a similar effect as our big traumas that we encounter. We often think about traumas with a small t here in these three categories: abuse, neglect, and household dysfunction. But we all know as well too that not everyone who actually suffers from abuse, neglect, or household dysfunction actually falls apart. So we need to ask the question, why this person? Why is this person impacted by this? Why are they actually not doing as well as another person who may have experienced something very similar? And we need to actually then think about three main things. These are our contextual factors, the systemic factors, as well as the personal factors. Have they actually had some support in between or other systems in place to help to look after their needs and therefore help them to gain that little bit more resilience and be able to triumph over the trauma? These traumas themselves can also be known as ACEs, which stands for Adverse Childhood Events. And we know that when we actually do accumulate more adverse child events, it does actually directly correlate to having higher degrees of behavioral as well as physical and mental health issues. And those are as follows. In fact, about 67% of us in the community will have at least one of these adverse childhood events. But when we do get a cumulative amounts of these, when we get to 4 or more, it definitely leads to higher morbidity and also mortality, causing premature death. To explain this further, I'm going to show a little video here called What is Your Number Story?
Let's start here. The story of your number is the story of your ACE history, a score used to measure the number of adverse childhood experiences that happened to you before the age of 18. ACEs fall into three categories: abuse, neglect, and household challenges, and are so common that 2/3 of us have at least one. A landmark study found the higher the number, the more likely one can experience negative health effects like heart disease, diabetes, depression, stroke, and asthma. The number is connected to an increased probability of lots of bad stuff. But you are not a number. The number is simply an entry point to your own personal story. Where it leads is up to you. ACEs are not your fault. They happen to us, but they don't need to define us. No person with a 2 is the same as another person with a 2. Each 7 is different from every other 7. Each of us is a unique story, and we each have the power to determine how our own story turns out. Explore the story of your number. Understand how it impacts the children in your life, and take control of where your story leads.
So there you have it. I think it's important for you to understand so too, for all of us to understand actually, that AIDS themselves, even though they are standing for adverse childhood events, some of these factors themselves can actually happen to us as adults and can still actually hurt a lot and can actually re-exacerbate the actual trauma we have experienced in the past. Some will also ask too, why actually are we focusing more on childhood traumas and not other traumas in the community? And the reason is because when you look at childhood traumas, when the young person experiences these traumas, they actually don't have the skills or the abilities to always decipher what is actually happening there and may take on a lot more of the actual impact of the trauma without actually seeking the proper help or knowing how to actually seek that proper help from the parents or other adults in the community who they may not feel be able to trust. So that's the reason why it paves this actual this trauma to then be perpetuated down the track well into the future. Next question is, how common is trauma? So here are some stats for yourself to actually understand this topic further. In the community, when we talk about violence, violence is actually very common in the community. 2 out of 5 people in the community actually have experienced some form of violence in the past. And in this case here, when we look at the cumulative amount of violence suffered by those in the community, men actually outweigh women. However, if you look at our other topics, for example, our domestic and family violence and intimate partner violence, we can see that women themselves are overrepresented. And this is actually accounts for 5.1% of burden of disease in the community. In regards to sexual violence, which I know we also hear a lot about in the media, we can see here once again, women are significantly overrepresented in this area. And this accounts to be a $22 billion problem in the health system. In regards to child abuse, we can see here that 1 in 8 children are actually impacted by child abuse. And this is another $10.7 billion. So this is the reason why trauma itself is a really big area that we need to focus on and be able to address appropriately and be able to help to avoid this trauma being passed on from one generation to the next. Whenever we actually experience trauma or any kind of problem that actually rocks us to our core, we actually would have a certain response that actually comes from the trauma. And our automatic kind of stress responses themselves is what's often triggered initially, and then we can actually form some maladaptive behaviors. So just to brush up on the knowledge about our stress responses, our automatic ones, we often think about having a threat of some sort. So we often do cast our mind back and we talk about the actual caveman days when we might have a saber-toothed tiger at our door. What do we actually do? Well, I guess our automatic responses themselves can include a fight or a flight or a freeze response. And those are regarded as our primary stress responses that we will have, automatic responses that we will have to a sense of danger. The thing though is that in our lives there, although we don't have saber-toothed tigers at our door anymore, but the same kind of mechanisms that actually cause that response to happen in the first place are still perpetuated in our everyday world from our different stresses that we encounter in everyday life. Some of you may also know as well too that there have been some research talking about the fawn response, but fawn response themselves are known as a secondary response, hence the reason why I've not included that today. It's also important for us to understand the impact of the actual trauma and what does it actually do to our brain. But to help us understand this better, I'm going to show this little video of a hand model of the brain as described by Dan Siegel and presented here tonight by Russ Harris.
So let's just go through it again. You've got your spinal cord, you've got your reptile brain. Underneath your cerebral cortex, you've got your mammalian brain with the amygdala, the hippocampus, responsible for emotions. And then you've got your cerebral cortex, your thinking cap of the brain on top, and the medial prefrontal cortex right here in the center at the front, right there.
And with that little concept of how the brain is working,
let's just go through it again. You've got your spinal cord, you've got...
Let's press pause there.
So let's do
Come on, you can do it. All right, yeah. So, okay, with the actual model of the brain there, as you can see there from the video, your actual spinal cord is actually what actually keeps you alive. So it does automatic things like your actual breathing, your heart rate, things that you don't even have to pay any attention to, but are required for your everyday living and survival. And that's at the base here. You then actually have your actual thumb there wrapping around, which is the mammalian brain there we can describe, and that's where we are looking at emotions and being able to actually say, you know what, I'm going to feel things around me and going to be guided by that as well too. On the very top, you have your fingers wrapping over to form the actual thinking cap, which is then comes over the top, which helps us to then evaluate things in that way. However, when we actually are experiencing trauma, okay, or have experienced trauma for a prolonged period of time, your thinking center up here, your thinking cap, actually is actually underactive because you don't want to actually think hard about things and be able to weigh up your options. You need to actually look after your well-being, and you need to have fast decisions there. So you then actually have it offline, leaving your actual emotional part of your brain and your actual your brainstem there doing most of the heavy work. And as a result, your thinking center is underactive. Your emotional regulation center, where your actual where your ability to actually weigh up options and try to calm and soothe yourself, is also underactive. Your fear centers from the mammalian brain area is overactive, as you're always on the lookout for any hazards coming your way. And as a result, you're always going to be living in this kind of fight or flight situation. And you may even actually have a freeze situation happen where you actually are starting to dissociate and block out whatever is happening around you because this is too much to handle. With all these things in place, your memory system is also impacted. And in this case here, your memory system is for contextual memory is faulty. That's the reason why we often have our memories of our trauma being muddled or misunderstood or be actually scattered in a certain way. We're having a very hard time piecing the facts and the timeline together. So, in other words, with all these changes here in our brain, this is the same kind of concept there depicted in words instead. We actually have our functional MRIs showing the same thing happening. And what you can see here is this. You can see here that your warmer colors themselves are where you have higher activity. However, when you actually have a person with a lot of trauma and toxic stress, you can see how there's very little of that warm colors here in the front part of the brain, where you have the prefrontal cortex doing a lot of the actual association of memory building and soothing and thinking and regulation that way. That is all underactive. And you can see here, there's a big abundance of low activity in here, making it harder for us to then work on the actual emotions and be able to process it appropriately. As a result, when you actually have the actual concept of neuroplasticity in place, we understand that when we are using certain pathways more, they become stronger, become more predictable, and also become your actual your super highways where you can have very fast, free-flowing information flowing from one side to the other side of the actual brain. If they were actually underused, then of course those pathways themselves which are underused will then shrink down or be cleaved away and therefore become less common in the brain. And that's how we actually have our neurodevelopmental disruptions and changes in the area, and can even lead to our epigenetic changes in the brain as well. As a result, when we're always in the state of fight and flight and we're always looking for hazards coming our way, every single sound that we hear becomes a potential danger. Every single movement, every single expression becomes a potential danger heading our way. We would then actually create some maladaptive coping mechanisms to try and dampen down the actual fear response in ourselves. And with that in mind, there common things that people reach for would be things like, for example, the actual drugs, alcohol, and other substances to try to actually calm themselves down and to try to get some solace from this. As a result, we have some long-term impacts. this can actually affect our perception of reality, what is actually happening. Okay, it can actually constantly throw us into fight, flight, or freeze response, causing our cortisol levels to always be elevated, to actually be always on guard, always always aware, working overtime and overthinking things in that way. It also takes away that sense of safety in the world we live in, and therefore we are always on the lookout. And when this becomes too overwhelming, and when we're trying to do things to try and make things better, but it then falls flat in our face, then of course we then actually shift into our learned helplessness and hopelessness, and therefore we have that spiral into our depressive features that we often do term as depression. When we actually have more than 4 of these ACEs, our adverse childhood events, coming together in one individual, we also have some really scary stats. And these are people who actually have 4 or more ACEs will be about 3 times greater level of will have 3 times greater levels of lung disease and adult smoking, 11 times greater 11 times greater risk of shifting into IV drug use, 14 times the number of suicide attempts, and all of these features are explainable by the trauma they've experienced. So knowing the ramifications of trauma, as a clinician there, let's have a little moment here, because knowing that these patients themselves with trauma will come in with so much baggage, sometimes we will actually look at them and see nothing but a big barrier. Someone there in front of me is actually falling apart, but oh my goodness, I don't even know where to begin, and they're going to be there to slow my day down, and I don't want to spend time looking after them. But at the same time as clinicians, we can also actually take a step back and appreciate them as a rainbow. This person here have actually gone so long looking after themselves and trying to keep everything together, and they've actually now got a rich tapestry of life there behind them, experiences and different kind of things that they've actually triumphed. And we can take a very much of a strengths-based kind of a perspective to then actually be able to perceive them in this very positive way and appreciate them, and be able to help them then actually say, okay, what can we do to help you grow a bit more, help you then actually make that actual, take a few more extra steps here and help you to be even a better, stronger version of yourself, and therefore be able to triumph over all these traumas. This is the concept that Russ Harris have actually promoted in his books and his work when looking at people who have trauma histories. But before we move into our rainbows there, because I know everyone loves rainbows, I think it's important for us to also understand why is it so detrimental to see our patients as roadblocks. Because if we do see patients as roadblocks, it actually helps to reinforce the barriers that they have had to seek help. This could be personal barriers, social barriers, but also practical barriers, which have made it harder for them to seek the help that they deserve. But if we do see them as a rainbow, we could then be able to then find out, okay, how can we now actually intervene? Where can we actually help? How do we actually help? Okay, and be able to have a very much of this collaborative stance. And that is what we call trauma-informed care. It's about being able to ask what's happened to a person instead of what's wrong with a person, and be able to work in a collaborative manner to help them grow. And we can actually use our trauma-informed care through all areas of our health system, from primary prevention all the way through to supportive recovery for a person who have been traumatized and is trying to actually look after themselves and free themselves after trauma. And so therefore, with that in mind, the aim of trauma-informed care really is to safely shift a person towards post-traumatic growth. And just like the Phoenix here as well, they can actually grow and become better, stronger than they ever have been before. And we see some of these people who actually have gone through significant traumas actually do amazing things afterwards. And we owe it to our patients to be able to help them to assist them towards growing and become the best version of themselves that way. So with that in mind then, so now we actually know the concept of why we have trauma-informed care and what actually causes trauma in our community and how trauma impacts us and our patient we may be seeing in front of us. We also need to understand, so how do we actually do this thing called trauma-informed care? What are the core principles? And there are actually 6 core principles here that we need to actually know about. These are safety, trust, okay, choice, collaboration, empowerment, and respect for diversity. Let's dive into them a bit more now. When we talk about safety, we talk about our physical safety, social safety, as well as cultural, religious, as well as our psychological safety. And if we can actually respect all of these areas, all 5 of these areas, then we're off to a very good start. Because in order for a person to trust you and build a rapport with the client there, we need to make sure that they feel safe in our midst. Once we have that in place, we can then really work more on the trust. And in this situation here, we need to be able to be sensitive to our patients' needs. We need to be reliable and accountable because in the past there, people have let them down. So in order for us to build that trust, we need to be reliable and accountable. But we also need to be able to respect the boundaries. So we don't really want to be pushing a person too far and breaking them and causing them to then fall apart because that would then shift them into a situation where they are feeling unsafe and then they will shut down again. We do not want that to happen. So in regards to respecting our boundaries, it's also important for us to understand what is actually okay for us to share and what's not okay for us to share. And a patient will be able to guide you in that process there. So make sure you talk to them. It's kind of like when we see a child and when we actually have sent mum and dad out the door and we're having a time with the young person and then we bring the person's parents back in. If we actually ask the young person, what would you like me to share with mum and dad? Because I'm sure mum and dad would like to actually know what we spoke about. Being able to actually get their input is the same as what we're doing here right now. Only difference is that this person may not be a child, this person may be an adult, and but they do need to actually feel they're able to trust you to help them respect the boundaries and help them keep certain things private and confidential if needed until the right time comes. Choice is also really important, and because often when we actually are in situations where we actually have received trauma, we did not actually get a choice. We did not actually have the ability to show our autonomy and be able to select the best option forward. And this is a really crucial part of the collaborative process and it actually helps to empower the patient to actually help to actually work together. And this collaboration is this doing with instead of doing to kind of process. And once again, this actually helps to even out the power play between the clinician and the actual client, and therefore helps to improve the actual the healing aspects and helps the person here who have been traumatized to gain trust in another person around them and build relationships again and be able to learn that, okay, not all relationships are bad, not all of them are scary. I mentioned this term before already, empowerment, and it really is an acknowledgement and a validation of the strengths of the person there to help work with them together to achieve a greater outcome. And through empowerment, we do actually want to hear their voices and develop resources to actually help them actually build in that way. Resources themselves wise doesn't actually have to be like written things that we think about as resources in the community. Resources themselves could be actually simply strategies to help them actually learn how to look after themselves and know how to actually care for them and those around them who are dear to them better. And all this actually helps to lead towards our post-traumatic growth. Last but not least, we do have our respect for diversity. And when we talk about this area, we talk about race, gender, ethnicity, culture, and also ability, because we want to make sure we match what we're doing with the person's abilities and respect the diversity that we may have certain kind of things that we do in our culture, which may be different to theirs and might be a bit jarring. So be able to actually seek their input and seek their expert consult because they know what actually is most important for them and be able to actually support them in that way. So with these 6 core principles of trauma-informed care, now we can actually think about a little bit more about how do we now assess and manage trauma. Because now that we've got some frameworks in place, we can then shift into the next section. Before I do shift to the next section though, are there any questions, at the present moment that any burning questions you would like me to answer? If not, I'm going to press ahead. Going once, going twice? No? Okay, next. Let's go ahead. I might say the questions to the end of the presentation then. All right, yeah. So, assessing and managing trauma. Um, how do we actually recognize trauma? I think this is a really interesting concept because trauma itself wise can actually be very different depending on the person and how they actually have this trapped trauma energy inside them being expressed. So this is a really cool little diagram here. I quite like this myself. And we can have a lot of our physical as well as our emotional kind of features here and our psychological distress being expressed in this way. And this actually comes from the work done by Dr. Bessel van der Kolk, who is the person who wrote the book, The Body Keeps the Score, which is right here in front of you in the middle of the screen. This landmark work was actually done when he was the head of the PTSD unit over in, I think it was actually Boston, actually in the States, and he's still there now. And he was actually working with a lot of veterans who actually have returned home after spending time abroad, and actually were quite traumatized by what they saw, what they encountered along the way. And he actually pulled their data together and looked at how do they actually use different modalities to achieve the best outcomes, and that's how they actually came up with their book, and it documents their actual journey in doing so. So here are some other common kind of presentations that we may not actually know of or may not actually recognize as being our outcomes from trauma. So you can see there, the actual presentation of trauma can be quite wide and varied. When thinking about trauma, I think it's also important for us to actually understand that we can classify it in certain ways. So, so I think if we were to try and diagnose it and diagnose the trauma itself, we can often think about our acute stress responses and our PTSD, for example, for a post-traumatic stress disorder, and it's important for us to actually then understand what are the delineations, what are the differences here, because often if anybody in the community can actually have an acute stress response to a traumatic event. So for example, if I actually crashed my car like I did a few years ago when I got totaled on the freeway, then of course I would be feeling these features here of same features as PTSD, but the only difference is that the time frame difference. So you might actually have the actual agitation, you might have the avoidance. I don't want to go back and drive on the road yet because I have this intense sense of fear and threat. I might actually be re-experiencing the actual trauma. I might have nightmares, for example, or might actually hear crashes or loud noises around me and makes me really jumpy. All these features themselves are the same as PTSD. The only difference though is the time frame. For your acute stress responses, they will all resolve within the first month. Whereas for your PTSD, it actually is perpetuated and goes on beyond that time. Another common diagnosis that we often think about when we talk about trauma is our complex post-traumatic stress disorder. And I want to let you know that this is actually not the same as your borderline personality disorder, and I'll show you why in just a moment. Before we actually talk more about complex PTSD, you can see here this is the only one that is in the ICD-11 because it's not currently recognized by the DSM-5 criteria. But we actually have the same features as our PTSD plus an extra element, which are these extra elements are your affective instability, where you actually have quite wild mood swings. And that's often because we're trying to lash out before someone actually hurts us. We also have our severe but stable negative self-concept that's saying, oh, I'm unworthy, I'm a failure, or I don't deserve any of these positive things around me. And as a result, your actual interpersonal avoidance and difficulty maintaining relationships becomes a prominent feature here as well too. So you might actually ask them, so who actually gets complex PTSD? Complex PTSD itself wise often are suffered by those who actually are exposed to ongoing traumas and recurrent traumas, but are not able to escape from them. So for example, children, for example, who actually are living in households where they've been impacted by abuse or neglect, these are a very common feature of which can cause them to shift towards PTSD, a complex PTSD, sorry, because of this ongoing inescapable situation. Even though they could potentially run away, they probably wouldn't get very far given how expensive our world is, and then not having the actual adults in their life to fend for them. Hence the reason why they always come back. And we see this happen as well too in, say, our people who are having abusive partners in the community who may actually want to leave but are not able to do so for whatever reason, and therefore end up actually putting up with the trauma, putting up with daily kind of abuse, and therefore actually develop a lot of these complex PTSD features. In regards to borderline, okay, this one here is a common term we've thrown around a lot. Borderline personality disorder often gets a very nasty rap, and it is actually under the DSM-5 criteria, but we can see here that the actual trauma is not required, whereas trauma is required for both PTSD and complex PTSD. In BPD itself wise, you don't have to have trauma in order to actually have the changes and the developments to actually develop borderline personality disorder. What is a really prominent feature though of our borderline personality disorder is our anger, our recurrent suicidal and self-injury behaviors, and also as well too, this disturbance in our identity, where I don't actually have any thoughts about what I like, what I don't like, what I stand for, and anyway, and they will often gravitate and take on what is actually what are the actual interests of their peers. And this is actually a very interesting feature that we only see in borderline personality disorder, not in complex PTSD nor PTSD. Also as well too, in here we actually have this severe fear of abandonment. And this is because when anyone comes too close to a person who has BPD, they will often feel threatened because they're not sure if they really truly are able to experience this, because they are fearful of what this person may do afterwards. And therefore, instead of actually letting them in, they would be pushing them away at the same time, even though they really want to be cared for and be loved, they actually have this very bitter ambivalence between the two poles of emotions there. So it can be quite a sad situation there for them to be in, because it does make it very difficult for them to sustain a relationship. If you do want to find out more about the differences between PTSD, complex PTSD, and BPD, this is a cool little video. Unfortunately, it wasn't actually playing right tonight, so therefore I have to skip it. But if you do get time yourself, please do check it out, because I think it'd be worthwhile for you to check it out if you wanted to dive into this area a bit further. So therefore, now that we know a little bit more about the diagnoses that we can use to help us conceptualize common features in our trauma presentations and be able to understand it further, it's also important for us to then also know how can we actually assess, how can we ask about trauma, because this is also really important. And when we talk about trauma, it's really important for us to acknowledge the trauma, first of all, because it's important for the person to know that we actually believe them. It's also important for us to build a safety and rapport, and we do that by using the 6 principles of our trauma-informed care that we went through beforehand. Also, as well too, it's important for us to explore in a trauma-informed manner. And what that actually means is that we don't actually want to ask them a gazillion one questions and be able to find out all the ins and outs of everything about the trauma, because if the person's not ready to talk about that in that level of detail yet, that can actually significantly re-traumatize the person, and therefore be very unhelpful. And the poor person who actually has suffered the trauma will often leave there and never want to come back again, because they don't want to go back through the actual same hurts that they experienced before in the past. So therefore, how can we actually ask these questions to find out more about what's happening and probe gently and know how to actually ask in a safe manner? These are some of the things we can use to help us out. This one here is from my friends over in the Psych Scene team, and these are some of the questions they actually suggested using as a very easy way to broach the topic, to explore the different aspects of our trauma, addressing all the common adverse childhood events. I just want to make sure everyone's on the same page here because I want to have one more point, and that is never force someone to debrief about this trauma until they are ready, because we would be running the risk of re-traumatizing the person. And this is what we found as well too in the PTSD as well, and even in any other situation in the community. Forcing a person to talk about the trauma will often make it worse. Let the person come to you instead, and that's the reason why we don't actually do any formal mandatory debriefing sessions after the event, like we used to in the past. Once we have asked the questions to assess the trauma, it's important for us to then actually take our 8 steps approach to our intervention. And what this actually is the 8 R's that we can talk about. Number 1 is to be ready, and to be ready to identify and respond to actually the violence or the trauma the person have experienced themselves. Number 2 is to recognize the symptoms of abuse or trauma and of violence, and ask directly, but also to ask sensitively and with a lot of tact. Respond is the next step, and that's respond to disclosures and practice our empathetic listening, so the person can feel they're able to trust you and that you actually genuinely care to find out more, and be able to respect the person as well too in the process. Next one is to assess the risk. So explore any risks and safety issues which may be actually behind the scenes, to then be able to then review the patient for follow-up and support. So we want to make sure they can come back, because you can't possibly do everything at once. And we want to be able to refer the person for further inputs. So be it actually another clinician who actually specializes in the area, or actually a person with other skills which they may be helpful for this person. And for ourselves, to be able to reflect on our own attitude, our management, our limitations, and to be able to address the actual trauma in that way, because we need to, as clinicians, know our limitations and know when to refer them out, or refer them on, or how can we work in a more collaborative manner with the person there. And the overarching quality of respect is important. Respect for patients, respect for your colleagues, and respect for yourself. Again, this is the most important thing that underpins the whole process. And once again, remember never to force someone to debrief about this trauma until they are ready to do so. So now that we actually know how to ask about it, and we've got a bit of a process for how do we actually address it, here's another way of conceptualizing this. So managing trauma in self-wise can be a multi-stage kind of situation, and we can actually use diagrams like this to help us actually work out the yes or no dichotomous kind of feature of what can we do next. So it all comes down to where your patient is up to in their trauma healing journey. So if you can actually have a very informative patient who is very, very savvy about the trauma and is ready and keen and would like to actually seek some further help, this is a person that you can actually refer onto the psychology teams and be able to actually get that input to really actually tackle and address that trauma there head on. But the thing though is that you may have a patient there who's actually feeling really overwhelmed by the trauma and not ready to actually engage in the trauma work yet, because that can actually overwhelm them and make them worse. So in this situation here, when you have a person who's experienced a lot of emotional distress and trauma from the trauma, then of course, helping them actually learn some self-soothing techniques will be very important, trying to bring their actual elevated state of distress back down towards a more manageable state. If you actually have an avoidant patient who actually who have disclosed the fact that they actually know that they have been traumatized in the past, but are not ready to talk about this or is very dismissive about the trauma, then of course, in this situation here, if we can actually let them know that trauma is very important and very common, and if they are keen to talk about this in the future, then they can always come back and see yourself if you are happy to be there to support them in this process. And that ability to sow the seeds to help them actually know there are safe people in the community who they can turn to get this help would actually be very helpful. So when they are ready, they will often think about yourself and come back to see you to actually get this extra input. So therefore, you can see here that patient factors themselves are extremely important when coming down to what do we do in our management plan. We can also have a stage management as well too, where we can think about what do we actually aim for first of all, and what do we aim for next, and so on and so forth. So first step will always be to build safety and stabilize the situation. And this is on the basis of the work done by Dr. Joanna Lynch, who actually have done a lot of work here in the trauma aspects in Australia. Once we actually have a safety and stabilization in place, then we want to be able to grapple with the trauma, but only when the person is ready for that. And beyond that stage of grappling the trauma and putting that into its rightful place, then of course be able to consolidate and grow. This is where we're actually aiming for our post-traumatic growth that we mentioned beforehand. So this is often a way for us to help us to actually guide us to understand where is my patient up to, what would be the most important thing for them to do to help them in their recovery journey from their trauma. When we're talking about our recovery journey from trauma as well too, it's also important for us to consider our needs. Maslow's hierarchy of needs is actually a very helpful way to consider this. Unless we actually have our kind of basic physiological needs met and our safety as well needs met, those two are definitely precursors there before we can actually dive into any trauma work. Because if you are actually having a very chaotic life there, and you see so much happening in the world around you, making you feel overwhelmed, you'll constantly be putting out spot fires and you will not be able to dive into anything meaningful, and therefore they would not be ready for that trauma work yet. So very important for us to actually then help to support them still, because we can still do a lot of work here. If they're not ready to dive into trauma work, trying to help them to feel supported, help them to feel safe and protected, and help them to get a sense of belonging, both in the community and in the cultural aspects there. So therefore they can feel like they're part of the community and feel safe. And that will then help to satisfy the requirements for our basis of the Maslow's hierarchy of needs, addressing the actual basic physiological needs as well as safety needs before they can actually, which would then help them attack the actual the other aspects of the trauma to then unlock the levels above. So a lot of talking here, of course, on my side. So I guess what does actually help look like as well too? Because I can tell you right now that for us clinicians out there who actually are able to prescribe, I can tell you right now medications themselves is only just a very small part. We need to actually be able to lean heavily on our colleagues who actually work on the psychological aspects there. So psychology input itself can be many and varied, and it depends on the actual clinician and what their skills are. So actually do spend some time finding out about who in your community is interested in trauma work and who actually has the skills to do so. So they could be working in aspects of CBT, where we are looking at how our thoughts impact our feelings and impacts our actions, and how that then feeds back to our actual thoughts, and it forms a continuous feedback loop. And if we can actually address certain ways of actually seeing things, thinking about things, and therefore how we then do things as a result, that can then actually make a difference for a person who have been traumatized. ACT itself is another one that can be very helpful. And in this situation here, we actually have a hexaflex of 6 different aspects, which we can use to actually build flexibility into a person's life. So they don't actually have a single track mind, focusing just on the trauma and nothing else. And if again, having that actual flexibility, having that actual repertoire of skills, repertoire of experiences, activities, and draw on, they can actually enrich their overall sense in their life there and feel a bit better connected that way. DBT itself wise is very similar to CBT, but the thing is, with DBT itself, they also have a significant focus on emotional resilience and looking at how we can bring down the actual emotional distress and learn how to surf that emotional distress. And there are definitely clinicians out there who do a lot of good work in this area, especially in trauma and very important that we actually are considering these groups in the community for people who may have more of a BPD kind of flair to their presentation. Schema therapy, works to actually address the actual unspoken rules that we have written in our brains and our minds, and how do we actually approach certain things. So these rules themselves may not always be correct, and more often than not are actually flawed. But the thing though is that we still stick by them until we actually are aware that they don't serve a purpose anymore. and then we can rewrite the programs to help us with that process. IPT itself wise is another one of the modalities, and this is especially good for people who have interpersonal or grief kind of related responses to their trauma. For example, they may not be able to actually go back and actually make amends to certain things that they have done in the past there. And EMDR is another great one there for our PTSD. This is kind of a really helpful way for helping people to look at their trauma and address it by actually putting it into the rightful place and be able to tone down the actual distress they're getting from the actual traumatic events or the traumatic memories that always are coming back up to the surface. There are other ones out there as well too. Okay, not everything in this picture here are actually founded in the same degree of evidence, but there actually have been some work on the neurofeedback side of things, looking at our other kind of mindfulness practices that actually helps to soothe us and calm us. But definitely helpful for us to consider these as a modality in the future, should the other ones on the left-hand side not be actually working in your patients. Coming down to our guidelines in Australia, there actually are some PTSD guidelines available online, and it's available via the Phoenix Foundation. In regards to first responders and emergency workers, we actually have this guideline here from the Black Dog Institute, and this is the guideline from the Phoenix Foundation there, looking at PTSD and what medications we can use to help to reduce the distress and be able to help to work side by side with the psychology work that the person is doing. So definitely worth us checking it out if we actually need to reach for that in that way. With all this talk about looking after our patients, it's also really important to look after us. So make sure we look after our ABCs. ABCs themselves stands for awareness of your own needs, emotions, and limits. Be able to help you seek that balance between your work, leisure, and rest, but also your connection to those around you, to yourself, to others, and to something greater. And if you pay attention to ABCs, that will definitely help you to actually be a safer clinician in the community and avoid burnout. So taking the topic further, if you actually have if I've actually whetted your appetite tonight in this area, please do check out these publications, the White Book. Phoenix Australia has lots of great publications, as well as the Blue Knots group as well too, who do really good work in trauma in Australia. But also as well too, Gabor Mate and Dr. Bessel van der Kolk, which I mentioned before, both of them have written extensively about this topic, and they do form a lot of links between trauma and how do we actually perceive it in the community and also in our patients as well too. And where would we be without Brene Brown as well too, who talks a lot of that compassionate work and looking at the vulnerabilities in ourselves and how do we address that in that way. So question is, what will you take back to your practice? And I hope you've learned a few things tonight to be able to actually start this journey to actually look at our patients who have experienced trauma in maybe a little different light, be able to consider them instead of being roadblocks and consider them as rainbows instead, and be able to then actually appreciate the rich tapestry of experiences they've had and also the strengths that they have as well too, to actually bring them to this point in time to come and see you, and then help them to grow as a person and help them then move on to the next stage of their life there. Because trauma itself is very common. Often actually are founded on adverse childhood events. We can use our 6 core principles of trauma-informed care to improve our ability to engage with people who have been affected by trauma. And we can use our 8 steps as a result to actually work through how do we actually provide appropriate interventions there. Always develop your patient's readiness for input, because that's going to be important to then help us to select the right kind of treatment for them at the right time. Remember that psychological input is the main treatment, but we can use a medication on the side there to actually help to work as an adjunct and make sure you look after you. I'm going to pass this presentation now on to Jamie, who is going to take us through the health pathways section.
Thank you, Gordon. Gee, that was such an excellent presentation. It was hopeful and thorough and extremely practical.
Thank you.
Now, I am hoping that most of you in the audience are familiar with Health Pathways already. Now, I just wanted to let you know that this is a point of care resource for primary care clinicians, and the Pathway passwords and usernames are there on your screen if you want to take a screenshot, but they should also be in the slide deck as well. Next slide, Gordon, thank you. So trauma-informed care is a very hot topic at the moment. I wanted to let the audience know that Central Coast and Hunter New England Health Pathways are very soon, in the coming weeks, soon to adopt a trauma and make live a trauma-informed care health pathway. Originally, it was developed by some people up in Queensland. Southeast Sydney have also collaborated with our region to write this pathway, and it's going to be live very soon on our websites. So watch this space. There are several sections in the pathway. The top section is mostly a resource and an educational reference point for us as primary care clinicians. And then the second part of the pathway talks more about how we would approach caring and supporting for patients who've experienced trauma. Next slide. Thanks, Gordon. Next slide. And there is the final section down the bottom highlighted here, which shows that there are some resources for both patients that we can point patients to, as well as for health professionals. And I'll leave some more questions, time for questions, but just to remind you that those are the password. Thank you. Back to you, Gordon.
Thank you so much, Jamie. So as I mentioned before, okay, love to have your questions. And when you actually do get the slide deck as well too, you can see all the references in the back there.
Thank you so much, Gordon. That was amazing. First question that we had come through was no question, but super fascinating stuff. So great comment, feedback. Please pop those. Please put those in the question box as well if you just have any feedback for Gordon, because I thought that was really fascinating. I learned a lot personally. So I'd love to hear anyone else's feedback. We'll see if any trickle in, and if they don't, we can wrap up and then get their feedback in the evaluation. But I loved it. Thank you.
Yep, thank you so much. Oh, I think there's a question there. Okay, so Kelly have asked, is there any advice if despite your best efforts, patients present only in crisis? Oh, good question. I think the most important thing is helping to actually to gently coach them as well, to be able to actually help them understand that they don't just have to come in a point of crisis. I think it's like it comes down to how they perceive the care that they receive from those around them. If they actually are used to coming when something's wrong, then of course they will often do so in a point of crisis, call up your front desk, ask for appointments right there on the day, and they go, can you please squeeze me in? I need to be seen today. And and that can be very difficult for the clinician and also very difficult for the patient as well too, if they actually are not able to do so and calling around to every single place they can think of to try and get in. So therefore, so being able to actually bring them in on the day when you see them, but then being able to help them actually make a follow-up appointment and set a really, really clear plan in place. Often when there actually is a clear plan, the person will have less chaotic kind of approach to their healthcare and will often actually respect that, okay, I'm meant to make sure I'm coming to this next appointment and I can save up things till then, and ask my questions then, and I know that this doctor is going to be there to care for me, and they've actually put aside time for me already, and they've actually made sure that we actually have a good plan and I know I'm being looked after. At the end of the day, that's what everyone wants to do, to feel like they're looked after by you.
Yeah, that's a good answer. Couple feedback comments. That was amazing, and I learned a lot. So again, well done, and thank you so much for a wonderful presentation. And we have had a few love hearts pop through as well. So that's amazing.
Thank you.
And let's see. Really enjoyed the presentation, Gordon. Looking forward to heading into work tomorrow and putting some of what I've learned into practice. Do you have any tips or advice for working within a team of clinicians who may not share the knowledge or openness to work to trauma-informed care principles?
Yeah, it is a tricky one, unfortunately. So I know that depending on where you are, we will all have different levels of understanding and knowledge in this area. And some of us may actually be very kind of dismissive as well too for trauma, and we don't actually recognize the big role it actually plays in our lives. I think being able to actually help your colleagues grow as clinicians by helping them understand the importance of addressing trauma, importance of mental health, and be able to respect the patient in that way can be really helpful. I think being able to kind of call out gently as well too that kind of this is an area that's important to us and we may need to find out more. Um, Another one as well too could be actually inviting them to talk to this, for example, being able to help them actually educate them, put them in the right direction. If you are actually a supervisor for a junior doctor, being able to maybe raise this as a topic to actually discuss and go through that together. If you do actually have, say, a group in, say, your actual practice meetings or actually having, say, your journal clubs, etc., which some people do run in their own practices or outside in your own peer groups, be able to bring up this as a topic to discuss and explore. Because I'm sure that every single person in the community who works as a clinician would have patients who actually have experienced trauma in the past come and see you as a clinician. So it definitely can be actually it will be definitely very helpful for us to learn more about that in that way.
Yeah, no,
So I'm
that's
gonna be
great.
tongue
Now,
tied with dry in my mouth too. Oh,
that's how I always feel in these things. Well, we're on 7 o'clock. No more questions have come through, so we will wrap it up.
sure.
But like Gordon said, this talk will be, it has been recorded and it will be available on our website. It should, I'm going to try and get this up for you as soon as I can. So hopefully, maybe even tomorrow, I might sneak on my day off and put it up for you because I just thought it was so important. Share it with your colleagues, send them the link,
Mm,
have a little watch in the
yeah.
YouTube channel.
And you know what,
Just
actually? When the actual kind of the Health Pathways does come live as well too, give your colleagues a nudge and say, check it out.
I love it. Now, Olivia, if you're on there and you wanted to pop back on to say goodbye, that would be wonderful. But a huge thank you to Jamie as well for her help pointing
Yes.
us in the new Health Pathways directions.
Thank you, Sydney. Thank you, Gordon, so much. This has been an amazing, amazing, amazing presentation and a great topic that is so current and so important for all of us as clinicians to know about it, whether we're mental health or primary health or physical health. I think it fits into every area of clinical practice. Sydney, thank you so much. You have been amazing, amazing, amazing in making these presentations to happen. I will never be able to tell you how much I appreciate you and appreciate your input and your help.
Oh,
Definitely
thank you.
so. I think Sydney's been amazing. So thank you so much for all your help as well too.
Thank you,
Thanks, guys. Well,
everyone.
have
Thank
have
you.
a wonderful night and thanks for coming.
Good night, everyone.
Good
Thank
night.
you.
Thank you so much.